Usually when we talk about a medical diagnosis, there's this underlying expectation of precision.
Right, like engineering.
Exactly, like engineering. You break your arm, the x-ray shows that jagged white line on the radius, and the doctor just points and says, there it is, broken.
It's binary. It's clean. And honestly, it's comforting. I mean, in medicine, we desperately want things to be visible and easily categorized.
But then you step into the world of antimicrobial resistance, and suddenly that x-ray machine is fundamentally broken.
Oh, completely.
We are looking at a diagnostic and therapeutic landscape that is incredibly murky. So, welcome to this deep dive for the Evidence at the Bedside series. I'm Dr. Taylor.
And I'm Dr. Griffin.
And we are taking the dense, highly anticipated 2024 IDSA guidance on the treatment of antimicrobial resistant gram-negative infections, and we're distilling it into actionable pearls you can take straight to the bedside.
Yeah, and the overarching theme of this deep dive is a major paradigm shift in how we practice. I mean, we have to completely move away from empiric, broad-spectrum guessing games. We're now in an era of mechanism-driven precision medicine. You just can't throw big gun antibiotics at a fever anymore. You have to understand exactly how the bacteria are fighting back.
Right, but before we even choose an antibiotic or, before we even glance at a susceptibility panel, we have to ask a foundational question.
Oh, the colonization question.
Exactly. This is especially crucial for the non-fermenting environmental organisms we'll be discussing today. As the clinician standing at the bedside, you have to ask, is this colonization or is this a true infection?
Because treating colonization is arguably one of the fastest ways to breed further resistance.
Yeah, it's not harmless.
Not at all. Every unnecessary dose of a broad-spectrum agent isn't just a benign, better safe than sorry decision. It is actively applying evolutionary pressure to your patient's microbiome.
We're essentially providing the training ground for bacteria to defeat our best weapons. I see that all the time. A patient has a chronic indwelling Foley catheter. The urine culture grows something terrifying, but the patient has no fever, no leukocytosis, no symptoms. Treating that lab result is a trap.
A massive trap.
So let's start with the most frequently encountered antimicrobial resistant threat on the wards. This really serves as the starting point for modern resistance management.
ESBLs.
Right. Extended spectrum beta-lactamase producing enterobacterales, or ESBL-E. Here is the clinical scenario that always trips people up.
Let's hear it.
Your patient's blood culture comes back growing an ESBL-E. coli. You look at the in vitro lab report, and it technically says the bug is susceptible to piperacillin tazobactam.
Oh, yeah, the classic pip-tazobate.
Right. It might even say susceptible to cefepime. And as a clinician, my instinct is to use the pip-tazo to save our heavier artillery, but the guidelines strongly advise against using it for invasive infections. Why?
So this is where we have to recognize the profound difference between a highly controlled lab environment and the sheer chaos of a human infection. The definitive answer on this comes from the Marino trial, which is a landmark study you absolutely need to know.
Right. Marino changed everything.
It really did. This trial cemented carbapenems, specifically agents like meropenem, as the absolute gold standard for invasive ESBL infections. They randomized patients with ceftriaxone-resistant E. coli or Klebsiella bloodstream infections to either piperacillin tazobactam or meropenem.
I remember when that data dropped. It caused absolute chaos on the wards because we'd been relying on pip-tazo as carbapenem-sparing therapy for years.
Right, everyone was doing it, but the mortality difference was stark. I mean, a 30-day mortality of 12% for the piperacillin tazobactam group compared to just 4% for the meropenem group.
Wow.
Yeah, there's a massive mechanical failure happening in vivo.
So break down the inoculum effect for us. Why does the pip-tazo shield break under heavy fire?
It comes down to sheer volume. In an invasive infection, like a deep intra-abdominal abscess or a roaring bacteremia, you have a massive bacterial burden.
Millions of organisms.
Millions upon millions. And this heavy inoculum essentially overwhelms the tazobactam component. Remember, tazobactam is the beta-lactamase inhibitor. It's basically jumping on a grenade to protect the piperacillin.
Okay.
But if there are too many grenades, too much ESBL enzyme being produced by this massive colony of bacteria, the tazobactam gets depleted.
And once the inhibitor is gone, the piperacillin is completely defenseless.
Precisely. And on top of that, standard MIC testing, the minimum inhibitory concentration lab test, is notoriously poorly reproducible when ESBL enzymes are highly expressed.
Because the lab well is static.
Exactly.
Yeah.
The little plastic well in the lab has a fixed, standardized concentration of tazobactam that simply does not reflect the dynamic, overwhelming reality of what's happening in the patient's tissues.
So the lab report says susceptible because the tiny controlled sample of bacteria in the well couldn't overpower the fixed dose of tazobactam.
You got it.
But in the patient's bloodstream, the bacteria are winning the numbers game. So we must use meropenem. But we also know carbapenems are a precious resource.
Right, we can't just hand them out like candy.
Exactly. We don't want to leave patients on IV meropenem for a 2-week course if we don't have to. What is the physiological nuance for stepping down therapy?
You're exactly right. We have to protect the carbapenems. Once your patient is hemodynamically stable, and this is crucial, once you have achieved definitive source control, like draining the abscess, you need to step down.
Assuming the isolate test's susceptible, of course.
Yes, assuming susceptibility, you should transition to highly bioavailable oral options. We're talking about trimethoprim sulfamethoxazole or fluoroquinolones like ciprofloxacin or levofloxacin.
And the key word there is bioavailable. We are picking drugs that, when swallowed, achieve serum and tissue concentrations that practically mirror IV administration.
That's the only way you safely get the patient off the IV carbapenem and out of the hospital.
Makes perfect sense. So ESBLs are a problem of sheer volume and loud resistance. The bacteria are constantly broadcasting their ability to chew up penicillins and early cephalosporins.
Very loud.
But evolution is tricky. If we look at the next survival strategy, bacteria don't always want to waste energy producing enzymes 24/7.
Right.
Some of them hide their resistance until we provoke them. Which brings us to AMP-PC beta-lactamase producing Enterobacterales.
The sleeper cells.
Sleeper cells. Now, in medical school, we were all taught the SPACE or SPICE acronyms to remember these bugs. Serratia, Pseudomonas, Acinetobacter, Citrobacter, and Carobacter.
Oh, yes, spicy.
But my understanding is that the 2024 guidelines basically tell us to throw those acronyms in the garbage because they oversimplify the clinical risk. So who are the actual culprits we need to worry about?
Yeah, you can officially forget the spicy acronym. The guidelines ask us to focus hyperspecifically on the big 3 organisms that are at a moderate to high risk for clinically significant inducible AMPC production.
Okay, the big 3. Let's hear them.
You need to memorize these 3. Enterobacter cloacae complex, Klebsiella aerogenes, and Citrobacter frundii.
Okay, Enterobacter cloacae, Klebsiella aerogenes, Citrobacter frundii, the big 3. Let's walk through the mechanics of how the sleeper cell actually wakes up, because this leads to what we call the ceftriaxone trap.
Oh, the ceftriaxone trap is one of the most devastating pitfalls in clinical practice.
It really is.
So you might have a patient with a Klebsiella aerogenes bloodstream infection. The initial lab report comes back, and it looks beautiful. It says it is wide open, susceptible to ceftriaxone.
So logically, you start ceftriaxone.
Right. But exposing that specific bacteria to that specific drug triggers a genetic sensor. It literally signals the inducible AMPC gene on the bacterial chromosome to de-repress.
It's like flipping a light switch from off to blindingly bright. The bacteria suddenly starts hyperproducing these AMPC enzymes right in the middle of your therapy.
Exactly. Treating these big 3 organisms with ceftriaxone carries a roughly 20% risk of inducing resistance while you are treating the patient.
That's terrifying. 1 in 5.
Yeah. You will watch the patient initially improve and then suddenly spike a fever and crash. The clinical failure happens right before your eyes, even though you picked a drug the lab said was perfectly fine on day 1.
So to avoid the trap, we need an alternative. But this is where the pharmacology gets paradoxical. I mean, for ESBLs, we just established that we should avoid cefepime because the enzyme eats it. But for AMP-C...
For AMP-C, cefepime is actually the preferred drug.
Walk us through that structural pharmacology, because on the surface, choosing a cephalosporin to defeat a cephalosporin sounds like a terrible idea. Why doesn't the AMP-C enzyme destroy the cefepime?
It's a brilliant quirk of molecular design. Cefepime is a 4th-generation oxyminocephalosporin. First, it is a very weak inducer of the AMP-C gene, so it doesn't flip that light switch we just talked about.
It lets the sleeper cell sleep.
Exactly. But even more importantly, its physical structure forms a highly stable acyl enzyme complex.
Meaning, when the AMP-C enzyme tries to bite the cefepime molecule to break it apart, the cefepime jams the enzyme's jaws.
That's a great way to visualize it. Even if there is some basal AMP-C enzyme floating around, cefepime resists being hydrolyzed by it. It withstands the enzyme's attack, remaining intact and able to destroy the bacterial cell wall in a way that ceftriaxone simply cannot.
That is a phenomenal distinction. So for ESBLs, avoid cefepime, use carbapenems. For AMP-C, use cefepime, avoid ceftriaxone.
Spot on.
But let's follow this evolutionary arms race to its logical, terrifying conclusion. If our standard cephalosporins are neutralized by AMP-C and ESBLs, clinicians naturally reach for our big guns, the carbapenems.
Yep.
But bacteria reproduce every 20 minutes. Eventually, they evolve enzymes to destroy our gold standard. This drops us into the high-stakes world of carbapenem-resistant Enterobacterales, or CRE.
And this is where empirical medicine completely dies. You cannot guess your way out of a CRE infection.
Because CRE is not a single disease, right? It's a phenotype. It just means resistant to carbapenems, but it doesn't tell you how it's resistant.
Exactly. It's a category with many different molecular masks.
So how does a clinician navigate this when their empirical carbapenems fail?
You absolutely must pick up the phone and call your microbiology lab. You need to know the exact carbapenemase enzyme the bacteria is producing. Mechanism-driven therapy is the only way forward here.
So phenotypic resistance testing isn't enough anymore?
No, you need the molecular genotype.
Okay, let's break down the approach based on those specific enzymes. What's the most common one we see in the U.S., and what is our counterattack?
The most common is KPC, which stands for Klebsiella pneumonia carbapenemase, though it frequently shows up in other bacteria too.
Right.
For KPC, we have incredible newer beta-lactam and beta-lactamase inhibitor combinations. The preferred agents are ceftazidime avibactam, meropenem verbactam, and imipenem cilastatin relebactam.
So these new inhibitors, the avibactam, verbactam, relebactam, they're specifically designed to bind and neutralize the KPC enzyme.
Exactly.
Okay, and what if the lab calls you back and says it's an OXA48-like enzyme?
Then your options narrow. For OXA48-like producers, the preferred agent is ceftazidime avibactam. The avidobactam component is uniquely effective at inhibiting that specific OXA48 structure, whereas verbactam and relebactam are not.
Which is exactly why you have to make that phone call to the lab.
You have to make the call.
Okay, let's push this to the absolute limit. You call the lab, the patient is crashing on maximum pressure support in the ICU, and the microbiologist tells you the isolate is producing a metallobeta-lactamase, an MBL, like an NDM enzyme.
Oh, boy.
Right. Now, these metalloenzymes are structurally totally different. They use zinc ions in their active site, and they basically act like molecular buzzsaws.
Yeah, they just shred everything.
They chew through penicillins, cephalosporins, and our precious carbapenems. And worse, our new inhibitors like avibactam and verbactam do absolutely nothing against them. What is the strategy here?
MBLs are the nightmare scenario, but the IDSA guidance outlines an absolutely ingenious bypass strategy. Dual therapy with ceftazidime avibactam plus aztreonam.
Wait, let me make sure I understand this mechanically. We are giving two entirely separate beta-lactam antibiotics at the exact same time.
Yes.
Isn't that redundant? Why does aztreonam fit into this?
It sounds redundant until you look at the enzyme structures. MBLs hydrolyze almost everything, so they have a very specific blind spot. They cannot hydrolyze aztreonam.
Oh, wow.
Yeah, the unique structure of aztreonam allows it to evade the zinc-based buzzsaw completely.
Then the obvious question is, why not just give aztreonam by itself? Why add the ceftazidime avibactam?
Because bacteria don't just rely on one weapon. An organism that has acquired the genes to produce an NDM metalloenzyme almost always co-produces other serine beta-lactamases at the same time, like ESBLs or AMP-Cs.
And those co-produced ESBLs will instantly destroy the aztreonam before it can do its job?
Precisely. So you administer ceftazidime avibactam to act as a bodyguard.
A bodyguard. I love that.
Yeah, the ceftazidime is basically irrelevant here. You're giving it entirely for the avibactam. The avibactam sweeps through and neutralizes the ESBLs and AMP-Cs, clearing a safe path.
And then the aztreonam, completely unaffected by the MBL, slips through that cleared path and kills the bacteria.
Exactly. You are essentially using the avibactam to protect the aztreonam.
That is pharmacological wizardry. The bodyguard and the assassin working in perfect tandem.
It really is beautiful.
Now, so far we've been talking about Enterobacterales, bugs like E. coli and Klebsiella that rely on stealing specific genes like these carbapenemases to fight back.
Right.
But our next organism takes a totally different evolutionary path. It doesn't just build weapons, it builds physical walls. We are talking about Pseudomonas aeruginosa with difficult-to-treat resistance, or DTR Pseudomonas. I liken it to a castle under siege.
It's the perfect analogy. So how are the bacteria fortifying the castle?
Well, normally antibiotics flow into the bacteria through these microscopic doors called porin channels, but when we attack, the Pseudomonas literally pulls up the drawbridge.
It mutates its porin channels so the drugs simply can't get inside.
Right. And if any antibiotic molecules do manage to scale the wall, the bacteria puts archers on the battlements. It upregulates afflux pumps to literally grab the drug and spit it back out into the bloodstream.
It's an incredible physical defense.
So how do the guidelines define DTR, and how do we breach those walls?
DTR is a strict, highly specific definition. It means the Pseudomonas is resistant to all traditional first-line anti-Pseudomonals.
So everything.
Everything. That means the lab report shows resistance to piperacillin tazobactam, ceftazidime, cefepime, aztreonam, all carbapenems, and the fluoroquinolones.
A total wipeout of the standard arsenal. So what is our battering ram?
Our high-yield choices are the newer beta-lactams. Cefcolozine tazobactam is a fantastic agent here. The ceftolozane molecule has a uniquely heady side chain. This creates massive physical steric hindrance.
Meaning the pseudomonal enzymes physically cannot close their jaws around the drug to break it apart.
Exactly. It's just too bulky. Furthermore, it retains strong activity despite those pore-in channel mutations and efflux pump-up regulations.
Any other options?
Yeah, ceftazidime avibactam and imipenem cilastatin rilibactam are also excellent preferred agents to breach the walls.
Now, what if you happen to encounter that rare Pseudomonas that has all these physical defenses, the drawbridge up, the efflux pumps pumping, but it also produces an MBL?
This is where we bring in the ultimate Trojan horse, cefiderocol.
The severiform cephalosporin. This might be my favorite mechanism in all of infectious disease. Walk us through how it exploits the bacteria's own survival needs.
It's amazing. So when a human body is infected, it goes out of its way to sequester iron, essentially starving the bacteria.
Right.
Pseudomonas desperately needs iron to survive, so it sends out its own cytophores to scavenge whatever iron it can find, and then actively imports that iron through specific, highly efficient iron transporter channels.
And cefiderocol structurally binds to free iron.
Yes. The bacteria grabs the iron, completely unaware the cefiderocol antibiotic is attached to it. The Pseudomonas literally pulls the cefiderocol inside the cell itself.
That is wild.
It completely bypasses the lost porin channels and the efflux pumps because it's coming in through the VIP iron delivery entrance. Once inside, the cephalosporin detaches and destroys the cell wall from the inside out.
It sneaks in through the enemy's own supply line. It's brilliant. But while Pseudomonas is a highly sophisticated, elegantly designed fortress, our next pathogen is just an environmental tank.
Oh, Acinetobacter.
Yes. It lives in soil, it lives in water, it lives on hospital surfaces, and it forces us to break all the traditional rules of antibiotic stewardship. Yeah. Let's talk about carbapenem-resistant Acinetobacter baumannii, or CRAB. This organism presents a fascinating pharmacological paradox in the guidelines.
It really does.
For SHRAB, we are relying on a beta-lactamase inhibitor as our primary weapon rather than the standard beta-lactam itself.
It is a total paradigm shift. Normally, inhibitors like tazobactam or sulbactam have no antibacterial activity on their own. They're just there to protect the main antibiotic.
Right.
But Acinetobacter is biologically unique. Sulbactam has intrinsic direct antibacterial activity against Acinetobacter because it happens to uniquely bind to the specific penicillin binding proteins, or PBPs, of this particular bacteria.
So the shield essentially becomes the sword.
Exactly.
Right.
Therefore, the preferred regimen demands a sulbactam backbone. You can achieve this using the novel agent sulbactam durlobactam, usually paired with imipenem cilastatin, just to cover other potential mechanisms.
And if that novel agent isn't available?
If it isn't available at your hospital, you use high-dose ampicillin sulbactam.
And we really need to emphasize the phrase high dose here. What kind of volume are we actually talking about for the patient?
We are talking about delivering a massive 9 grams of the sulbactam component daily. Not the total drug combination, just 9 grams of the sulbactam part alone.
That is a staggering amount of sulbactam. You're pushing the absolute physiological limits of what the patient can clear just to saturate those specific Acinetobacter PBPs.
You really are.
And the guidelines are very firm on another point regarding C. Monotherapy is dead, correct?
Absolutely dead. For moderate to severe C. RDAV infections, monotherapy is an absolute recipe for failure. The clinical data supporting any single agent is just too weak, and the organism mutates too quickly.
So what do we do?
You must take that high-dose sulbactam backbone and combine it with at least one adjunctive choice. You are usually reaching for agents like minocycline, polymyxin B, or cefiderocol to build a multi-drug regimen until you see definitive clinical improvement. You have to hit it from multiple angles simultaneously.
So you really have to hit Acinetobacter with everything at once. Now, Acinetobacter isn't the only opportunistic environmental pathogen lurking in the ICU. Our final pathogen shares a similar environmental origin. It loves water, it loves sinks, it loves plastic tubing, but it requires a completely different approach. Stenotrophomonas maltophilia.
They know.
Set the scene for us on rounds.
Picture a patient in the medical ICU. They've been on a mechanical ventilator for 3 weeks. They've been hammered with broad-spectrum antibiotics for previous pneumonias. And suddenly, their routine sputum culture grows Stenotrophomonas multifida.
Because it's a ubiquitous waterborne organism, the critical bedside dilemma pops up again, circling right back to the foundational question we started this deep dive with. Do we actually treat this, or is it just colonizing the plastic tubing of the ventilator?
And this was a major point of emphasis for the IDSA panel. You must always clinically correlate. You have to look at the patient, not just the paper. Unnecessary treatment of Stenotrophomonas colonization is rampant, and it is actively harmful. You really do. Right. Stenotrophomonas intrinsically produces 2 different enzymes, an L1 metallobetalactamase and an L2 serine cephalosporinase.
Twin engines.
Exactly. Twin engine resistance. Having both a zinc-based buzzsaw and a traditional enzyme, it is intrinsically resistant to almost all standard beta-lactams, including our carbapenems. We have 2 main strategies. The first is to step outside the beta-lactam class entirely and use combination therapy with agents that simply aren't affected by those enzymes. We are talking about minocycline, TMP-SMX, or levofloxacin. We borrow a trick from our CRE playbook, the ceftazidime-avibactam-PLUS-astrione-M combination.
Oh.
Got it. The mechanics are exactly the same as the NDM bypass strategy we discussed earlier. The Astrium evades the L1 MBL buzzsaw, while the avibactam neutralizes the L2 serine enzyme, allowing the Astrium to strike.
That's fantastic.
Also, the guidelines highly recommend cefiderocol as a preferred component in combination regimens because it has exceptionally potent in vitro activity against steno. Let's do it. Pearl number 1. For ESBLs, we must trust the Merino trial. Use carbapenems for invasive infections, and do not trust a susceptible piptazo lab report. The heavy inoculum of a real infection will overwhelm the tazobactam inhibitor. Pearl 3. For CRE, empiric therapy is over. Call the lab, get the exact molecular mechanism, and if it's an MBL, deploy the bodyguard assassin bypass with ceftazidime avibactam plus astrionem. Pearl 5. For SCRAB, monotherapy is a guaranteed failure. You have to build a multi-drug regimen anchored around a massive high-dose sulbactam backbone to directly attack the Acinetobacter's unique penicillin-binding proteins. Those are 6 phenomenal takeaways that will immediately change how you practice medicine. It's amazing science.
But elite.
That's a scary thought. It is a perpetual arms race, and continuing education is our absolute best defense.